Hi, and thank you for joining us right here at Breast Cancer Answers for a special international broadcast featuring our medical director, Dr. J.K. Harness, who's right now at the 8th International ISORT Conference in Cologne, Germany. Hi, Dr. Harness.
Hey, hello from Europe.
You know, Dr. Harness, over the years we've checked in with you when you've been in Singapore, in Ghana, Africa, Lima, Peru. I think when you were in Russia, we checked in with you, or
Hong
somewhere
Kong.
near there. Yeah, in
When I
Hong
was in
Kong.
Hong Kong. Yep.
Well, we're really getting you on the full tour. Can you give us the latest update of what is the state of breast cancer, our fight against breast cancer in Europe right now?
Yeah, very good question, Todd. You know, historically, the Europeans have been somewhat ahead of us in the treatment of breast cancer and doing new and sort of exciting things. They were the ones who invented the term oncoplastic reconstruction, oncocancer, plastic surgery. They've been ahead of us when it comes to meaning in the OR, intraoperative radiation therapy. And the initials you just gave everybody, ISIORT, stands for the International Society of Intraoperative Radiation Therapy. Now, intraoperative radiation therapy is used for things in addition to breast. So there's sessions going on right now on rectal cancer, using it there, and gynecologic cancers. We've got a good-sized group here from around the world, from Asia, the Middle East. Several good friends are here from the U.S. But sort of the bottom line of all this is the Europeans are real pioneers in the treatment of breast cancer, as I've just highlighted.
All right, so for those who may not know, you've been, really a thought leader in the intraoperative radiation therapy section of the treatment against breast cancer. For us lay people in the audience, explain what that means. I think it means, and correct me if I'm wrong, but while the surgeon's going through the procedure, they apply radiation inside of the breast directly to the tumor. Is that accurate?
Yeah, so the question, it's a really great question. So the question is, gee, Dr. Harness, what is intraoperative radiation therapy? What the heck are you guys doing? Todd, we need to remind our wonderful audience that when you do a lumpectomy of the breast, just take out the area where the cancer is with a normal rim of tissue around it, you do need to add radiation therapy to decrease the chance of the cancer coming back in the breast. Now, for the past 30 years or so, we've irradiated the whole breast. And then beginning in earnest, well over 10 years ago, we said, well, wait a minute. If the cancer typically reoccurs in the same neighborhood as where the lumpectomy was done, why do we have to irradiate the whole breast? Why don't we just irradiate the neighborhood, if you will? And so instead of whole breast radiation therapy, that's called partial breast radiation therapy, just radiating part of the breast. Now, prior to the intraoperative phenomena, one of the ways of doing that was to put a device in the breast called a brachytherapy device and give the treatments twice a day for 5 days, which is a lot better than the 6 weeks people were having to have. Well, then fast forward, people said, well, wait a minute, if we can do this in one shot in the operating room, wouldn't that be better? Or is it equivalent to? And that's where, again, the Europeans have taken the lead. Now, there are two other ways besides the at the time of surgery, at the time you're doing the lumpectomy, there's a thing in radiation therapy of the breast called the boost. What the heck is the boost? Well, after you go through 5 weeks of irradiating the whole breast, the boost is irradiating just where the cancer was. And we've known over the last 20 years or so that that's really effective in decreasing the chance of the cancer returning back in the breast. So our colleagues here in particularly Salzburg, Austria, and other places said, well, you know, we've got one of those big linear accelerators in an operating room. Can't we start doing the boost at the time of surgery followed by whole breast radiation therapy? And they began that process probably 14, 15 years ago. And as a result, they have one of the lowest recurrence rates in the breast any place on the planet. And so then, particularly in Italy, through Veronesi's group and some others, they said, well, again, let's, with now mobile linear accelerators, so you don't have to have one of these big, huge vaults, if you will, surrounded by cement and lead and a big, huge linear accelerator. If we can produce and manufacture mobile linear accelerators, can we use that? The Italians began that. And then one of our great friends at Breast Cancer Answers has been Intraoperative Medical. And we have several videos at Breast Cancer Answers talking about IORT, intraoperative radiation therapy. And frankly, that's a lot of what this conference is about. Can you imagine how expensive it is to have an operating room inside one of these great big huge vaults? So if you can do much the same thing with something that you don't have to have a vault, that's what's given rise to what's going on here. Does that make sense, I hope?
Yeah, that's remarkable. Thank you for explaining. Now, for those who are just checking in, Dr. Harness is in Cologne, Germany right now, where breasts and gynecological oncologists, radiation therapy experts from all over the world have come to Cologne to discuss topics from radiation technology to oncoplastic surgery. Dr. Harness, the rumors early on, knowing that you were going to Europe, were spreading on the internet that you're actually going to accept some type of Nobel Prize. That didn't happen on this trip?
You know, Todd, I have promised you that if I ever get the Nobel Prize in Medicine, I will personally invite you to join me. No, Cologne, Germany is a wonderful German city. I think this is either my third or fourth visit here. Many people may remember that it's really famous. In fact, I'm sitting, as I can almost see the cathedral out my window, the very, very famous cathedral, several hundred years old. My understanding is that during World War II, it was one of the beacons that pilots used to help guide them into this area. But I also understand that they really avoided trying to bomb the cathedral itself. And while there was lots of devastation around it, the cathedral is still standing. I had the privilege of being in it last night, as a matter of fact. You know, throughout Europe are these absolutely incredible cathedrals. And they're massive. I mean, it's almost as far as the eye can see going straight up are the spires and all the other things. So it's a real beautiful, German city, very Western European. The climate here is much like my native climate of Michigan. Lots of green. Right now, the daytime temperatures are in the low to mid 60s. So it's a pleasure to be back here again.
Now, I love that city. One of the things that's remarkable about that cathedral is, for most people, when you arrive in Cologne, you come out through the, look at us going Anthony Bourdain Travel Channel on everybody. One of the things that's interesting about that cathedral is, for most people, the first time you see it's when you step out the doors at the train station, and it's literally right there. So when you come out and it's black and Gothic, it almost looks like the an early version of the Star Wars Death Star. I mean, it's just imposing, and it's right there before you, and it goes bam. Welcome to Cologne. So, Dr. Harness, any exciting news that our audience around the world needs to know about information that's coming out of the ISIORT conference in Germany?
Yeah, intraoperative radiation therapy for breast cancer, Todd, is alive and well. A lot of the reports that have gone on here today have really indicated that in selected patients, so far in the short term, this is working. Now, I need to emphasize.
What do you mean by selected?
I was just about to say that. We figure that somewhere around 15, maybe as much as 30% of women who are eligible for a lumpectomy. In other words, they've got a small cancer, enough breast tissue so that if we remove the cancer, the breast still looks okay. But this is going to be a technology that's not for everybody. It's going to be a technology that we will be using in what we call lower risk patients. Now, what the heck is a lower risk patient? Our audience needs to remember that breast cancer is a galaxy of diseases. It isn't one or two or five or 10. It's probably hundreds at the molecular level. So the typical lower risk patient is somebody who has a small tumor, found usually through screening mammograms, is somebody where the tumor is what we call well differentiated, meaning that it kind of looks like the normal breast tissue. It's a tumor that would have estrogen receptor positive versus the really aggressive, let's say, HER2 new positive or triple negatives, which tend to be real aggressive. It's a tumor where the lymph nodes would be negative. It's typically somebody age 50 or a little bit older, although we can do intraoperative radiation therapy, at least in my institution, as a single shot in women as young as 40. And so that's what we're talking about. Now that's for the single fraction. In other words, at the time of surgery, you get it all done and you're done, period. You don't have to look at 5 to 6 weeks of radiation therapy later on. Now in the more advanced or bigger tumors, there's clearly a role for intraoperative radiation therapy as the boost that I was describing a few minutes ago to help reinforce where you took the tumor out, and then they do radiation therapy later on. Now, the Europeans have been leaders in what's called hypofraction radiation therapy. Typically in the US, we've talked about 5 weeks of radiation therapy. In many areas of Europe, they've shortened that down to 3 weeks. And then one of the really exciting research protocols being talked about at this meeting is one where you do that boost in the operating room and then follow it by 3 weeks of radiation therapy. And the idea here is this going to be as effective as 5 weeks? So I would say intraoperative radiation therapy is really alive and well right now.
All right, so if we bring this back to the patient, is that something that a patient should be asking for or questioning if it's an option for them?
Absolutely, they should be, Todd. Now, in the United States, we have a limited number of sites that are doing intraoperative radiation therapy. I can't give you the exact number. These are typically in larger metropolitan areas around the country. For those of us like my hospital that are doing the one time in the OR, we do these under research protocols so that we keep really, really close track of the patients. But we've said repeatedly here at Breast Cancer Answers, please make sure you're working with a multidisciplinary team. And that, by the way, has been emphasized time and time again throughout this meeting. I actually gave a talk this morning that our audience might be interested in. My talk this morning was on the treatment of breast cancer in the previously augmented patient. In other words, someone who has had breast implants done before they were ever diagnosed with breast cancer. The good news is the cancers are pretty much the same as the patients who have never had implants put in. In other words, the stage that we find them, the type of cancers, and the overall prognosis. The hard part with the augmented patient, if you do a lumpectomy, is if you do whole breast radiation therapy, you tend to form a thicker capsule around the underlying implant. And that can be sort of a problem down the road. But the good news is that even in women who have had prior augmentation of the breast, they too can have a lumpectomy. And I actually presented a case to the group today where we did intraoperative radiation therapy in an augmented patient. We need more research and more work on that.
All right. So how many people were in attendance today when you did your big presentation in Cologne?
Oh, I think 5,000 or 10,000.
No way.
Come on. I'm just kidding. No, I think we've probably got about 150, 200 people at the meeting here.
Well, the reason you caught me off guard, and you did what my family says, we just out-kidded the kidder. The reason you out-kidded me is because I instantly thought about, like, when you and I go to San Antonio, that
right.
when the San Antonio Breast Cancer Symposium, which for all intents and purposes is the biggest event in the world, right, for breast cancer.
Right.
I don't know how many people are in that room sitting down, but you can't see the podium. There could be 10,000 people sitting in that room.
And for that meeting, that's exactly right. It's usually probably about 14,000 or 15,000. I was kidding you. This is a very select group of people from around the world who are really focusing on intraoperative radiation therapy. And as I said, we've got well over 100, 150 people here from around the world. So it's really great. Now, one of the other really breaking news things here that I was personally excited about, one of the questions that's been asked time and time again about cancer throughout the years is, why doesn't the body recognize cancer as non-self and destroy it? And why doesn't our immune system, our killer lymphocytes, recognize cancer and just simply destroy it? One of the interesting presentations yesterday was from a German group where they were actually measuring the immune response, meaning does the body increase killer lymphocytes and things like that after a single fraction of radiation therapy? And the answer is, it appears that's what's happening. In other words, the radiation therapy is injuring the cancer cells to the point where they not only die, but when they die, they create an immune response. And this was really exciting. A lot more research has to be done in this area, and we'll be talking more here at Breast Cancer Answers in the future about immunotherapy, in other words, turning on the body's immune system. But I was particularly excited by this presentation yesterday on this very subject.
You know, that's so fascinating. You know, I remember when you were in Ghana, Africa, just a couple of years ago, and working with breast cancer experts on that continent. And when I was interviewing you from Ghana, you told me that, you know, how different breast cancer presents in industrialized countries compared to unindustrialized countries. And that's something that our audience is particularly interested in, you know, how different the frequency of cancer is in different parts of the world. How does breast cancer present differently, if it does at all, in Europe, which is, and for all intents and purposes, a very similar lifestyle that as we experience in the States?
Yeah, it's exactly the same as in the States, Todd. When we talk about the highest incidence of breast cancer in the world, we talk about Western Europe, where I am. We talk about the U.S., we talk about Canada, we talk about Australia and New Zealand.
Same lifestyle, same stresses, same products, right? It could be a combination
pretty much
of those
the
things.
same. These are cultures dominated a lot by Caucasians more than non-Caucasians. We're affluent, if you will. These are affluent parts of the world. Now, what's absolutely fascinating, and we don't fully understand it, we've always talked about Asia as having one of the lowest incidence of breast cancer in the world, that the Asian diet is no question how healthy it is. But what's interesting is, you know, you've interviewed me in Hong Kong once. I've been to Japan, Korea, mainland China several times now, Singapore, where else? Malaysia, Taiwan. What's interesting, particularly the more industrialized the countries become, the incidence of breast cancer starts going up. This is particularly true in Japan and Taiwan, also starting to increase in mainland China. Now, is it the lifestyle of more affluence? Is it delayed birthing, that people are having children much later in life, or as they do in mainland China, only one child? What are the factors? The bottom line is we don't really know. But for all intents and purposes, where I am here in Germany right now, it's the same as the U.S. as far as the incidence goes, what have you. Now, the important thing to emphasize to our audience that's different, let's say here versus Ghana, that was your question a minute ago, screening. You know, we've had some of the great experts in the world on our breast cancer answers, Dr. Laszlo Tabar, Dr. Robert Smith, and the others who have talked about the importance of screening, Lots of screening goes on here in Western Europe, particularly using MRI, which we don't do in the States. And so the earlier you find the cancers, the better. When I was in Ghana and you interviewed me there, Todd, people walk in with cancers the size of golf balls. They walk in with cancers that already affecting the lymph nodes. Now, in the U.S., we know that in African Americans, they tend to present at a somewhat younger age. Exactly the same thing is going on in Ghana. The peak age of breast cancer in Ghana is women in their 40s. And there's research going on, including by my former colleagues at the University of Michigan, looking at the molecular indications and measurements of the cancers in Ghana versus U.S. African Americans. Now, there's one other exciting piece of news that I know you're going to ask me about, and that is molecular and genomic profiling. Is that going to have a role in intraoperative radiation therapy?
All right, right. Well, don't leave me in suspense. Let's get to it.
Another piece of really good news here at this conference is that now more and more people are talking about the genomic profile of cancers. One of the reasons I'm proud that Genomic Health is one of our sponsors. They've been one of the real pioneers in this area. And as I've said, with this galaxy of different kinds of breast cancer, maybe the women who ought to have intraoperative radiation therapy have low-risk scores when it comes to the oncotype recurrence score. And I think what we're going to see in the future is more and more data being gathered on that very subject. And that's come up several times here. Today was devoted all day long to breast cancer. Yesterday was part of the other aspects, and then tomorrow will be the non-breast cancer. So yes, I think the genomic profiles are going to be important in helping us select patients for intraoperative radiation therapy.
Well, you know him as our medical director here at Breast Cancer Answers. I know Dr. Harness as the trusted advisor who sat up late at night on Skype many evenings helping my wife and I through her breast cancer. And internationally, he's been known as as a key figure in leading the fight against breast cancer for 30 years. And I'm sitting here back in Arizona waiting for my invitation from the Royal Swedish Academy of Sciences to finally award this man a Nobel Prize. And on behalf of Breast Cancer Answers, we want to thank you, Dr. Harness, for your tireless work for patients all over the world. And we look forward to having you back stateside soon.
Thank you, Todd. See you soon.
I'll talk to you real soon, my friend. Bye for now. Everybody have a very healthy and happy day. It's the only one that we are promised. Make it the very best.